Haematological. Anas, what's the name of that Ghanaian that was the Secretary of the United Nations? They say that man is a friend of Operation India.
Hi, good afternoon, everyone in Africa. So I think we can start the call. Today, I would like to welcome. Hello, am I audible, guys?
Yes, we can hear you, Dhruv.
Thank you, Nutan ma'am. So good afternoon, everyone. We will start this call as and when people join. We already have Dr. Vikas with us. He is a BMT specialist at Fortis Hospital. I would like to welcome him. Dr. Vikas, the platform is yours.
Thank you very much, everybody, for joining. I hope I'm audible and you can hear me.
Yes, doctor.
Thanks a lot. Fantastic. So thank you, Jivo, for giving me this platform to interact with our colleagues and friends back in Africa. And friends, as we speak today, the most common hemoglobinopathy, which is seen in whole of Africa, is sickle cell. And if I'm not wrong, Nigeria is the sickle cell capital of the world. We in India see a different type of hemoglobinopathy, which is called thalassemia. And that's why India is called thalassemia capital of the world. Whereas there are quite a number of sicklers which are born in Africa. And these kids are actually been suffering from a very long time since the time they've been born. They get.
So Vikas, sorry, I would like to interrupt here. So we have some doctors also from DRC Congo joining us. And we have a translator here. For first part of the call, Kambala will help translate. I would suggest that you complete one slide whenever you are presenting, and then he can translate the same in French so that the flow is not broken of yours or his.
Sure. So, so I'm just giving a brief background of sickle cell problem, which is there in Africa, which everybody is quite familiar with. And I would request Ms. Nutan, if you can share the slides with the audience so that we can start the presentation. Thank you very much, Ms. Nutan. I hope the slides are visible and we can start.
Yes, sir, we can start. Hi, Kambala, please translate whatever Dr. Vikas says after each slide.
Absolutely. I think that's very good that you have a translator for people who understands French better as compared to English. So why we are discussing this is the first slide. So let me just tell what this slide says. So this is a picture of a sickler which was made by somebody in US who is also of African origin, which about the pain which a sickle cell anemia patient goes through. So my friend, you can translate.
Pourquoi nous discutons? Ça, c'est un tableau de quelqu'un qui souffre d'anémia. Et c'est quelqu'un de l'Afrique qui a... Am I audible? Hello?
Yes, Kambala, audible. Please suggest when Dr. Vikas can speak once you are done with translation.
All right. Nous discutons de ça. Ça, c'est un tableau de peinture que quelqu'un a dessiné de la douleur que quelqu'un ressent lorsqu'il a l'anémie.
Kambala, you're on mute if you're speaking.
Sorry?
Yeah, you were on mute.
Yes, I said, okay, I was translating. Pourquoi nous discutons? On disait ça, c'est un tableau que quelqu'un a dessiné de la douleur que quelqu'un ressent lorsqu'il a atteint d'une maladie qu'on appelle anémie.
Dr. Vikas, you can continue, please.
Yeah, so as we are discussing on 28th July 2024, Friends, for this painful condition, the only cure remains bone marrow transplant. And the I would request everybody to please mute if possible. Yeah, so as we speak on 28 July 2024, the only cure for sickle cell anemia is a bone marrow transplant, and gene therapy is just under trial. And that's why we have designed this talk on role of bone marrow transplant in sickle cell anemia and in other hematological disorders. My friend, you can translate.
Comme on a discuté le 28 avril 2024, c'est pour ça qu'on a commencé avec ces systèmes de stem cell transplant.
So what we need to understand first is the basics of stem cell transplant. What are the indications? What are the donor types? How we do a transplant? How we collect the stem cells? What are the supportive therapy which is involved when we talk about bone marrow transplant? And what problems you can face when you do a transplant, and what medicines and what are the ways to prevent these problems is what we are going to discuss in the next 30 minutes.
On va discuter des stem transplants, l'implantation des stem cells. Et c'est de ça qu'on va discuter pendant 24 minutes.
Next slide, please. Let me tell you the basics of stem cells transplant first. The first successful transplant was performed for a patient of leukemia in 1969, and another common hemoglobinopathy which is seen in India, which is thalassemia. The first successful transplant for that was performed in 1981. You can translate.
La première transplantation a été faite à leukemia en 1969 par le docteur Donald Thomas.
Next slide. And for the work in transplants, this is the person who got a Nobel Prize in 1990 because he's the one, Dr. Thomas, who did the first successful transplant for a patient of leukemia. Please translate.
Ça, c'est la personne qui a reçu, qui a été médaillée pour la première transplantation. C'est Dr. Donald. I cannot see, sir, the name of the doctor.
All right. His name is Dr. Thomas.
Dr. Thomas. Par le Dr. Thomas.
Yeah, he got a Nobel Prize in 1990 for his first successful transplant.
Il a reçu un prix Nobel en 1990 en médecine, après cette transplantation.
Yeah, next slide. Yeah, so these are the sources. First, we need to know how we collect the stem cells. So we can collect the stem cells from the bone marrow, from the blood, or when a newborn baby is born, you can collect the stem cells from the cord blood.
Ça, c'est la façon dont on peut, la source des cellules souches. On peut prendre ça des os, on peut prendre ça du sang aussi.
Next slide. And these are the bags in which we collect the stem cells. Whatever is the source, whether it is a bone marrow source or a peripheral blood, which is a source, or the cord blood, which is a source. So these are the bags in which we keep the stem cells. Please translate.
Ça, ce sont des sacs où nous conservons les cellules souches. C'est dans ces petits sacs que vous voyez avec des sangs.
Next slide. When we talk about cord blood transplants, there are two types of cord blood banks. One is called a public bank, and second one is called a private bank. Please translate.
Là, ce sont des... Là, on réserve les centres du cordon.
So in a private bank, the stem cells are being collected. When a newborn baby is born, the stem cells are being collected and they go to a private bank in which for which the family pays money so that in case there's a need, the stem cells can be taken from that private bank and can be used for the same child or for the sibling. Whereas when you talk about public bank, the stem cells are being collected, goes to a public bank, and in case somebody needs that stem cells, then by a way of called HLA typing, you can see whether the stem cell unit is been matching with that HLA group, and that can go to anybody who's in a need.
Ça, ce sont les réserves du centre du cordon. On peut les transformer, les transmettre d'un sac à un autre. Et puis, c'est à partir de cela qu'on va faire des tests pour savoir si ça match avec la personne à laquelle on va transmettre ça.
Next slide. Okay, let me tell you the brief history of transplant. The first successful cord blood transplant. I request everybody to please mute. Can everybody mute? So first successful cord blood transplant was performed in 1988 for a patient of Fanconi's anemia in France, and the first international cord blood registry was formed in 1992. Please translate.
En octobre 1988, Gluckman a fait pour la première fois les UCBT. Je crois que c'est un test ou bien une opération à un enfant de 5 ans qui avait la Fanconi, l'anémia de Fanconi, et qui a resté genre stable hématologiquement et immunologiquement pendant 29 ans.
Next slide, please. As you see, this is the National Bone Marrow data, which is a US-based registry, that the number of transplants are increasing year by year, and the alternate donor transplants and the cord blood transplants are also on a rise. Please translate.
C'est un tableau qu'on va voir un histogramme de comment ça évolue de la transplantation des cellules souches. Vous pouvez voir de 1999 jusqu'à 2012 comment ça évolue, l'évolution.
Next slide. So this picture shows that there are two types of transplants. One is called an autologous transplant, in which the patient himself is the donor. And the second slide is called allogenic transplant, in which you require a donor. We will tell you the indications later, but just understand that there are two types of transplant. One is auto transplant, second is allo. In auto, the patient himself is the donor, whereas in allo transplant, you require a donor. Please translate.
Il y a deux sortes de transplantation des cellules souches. Il y a ce qu'on appelle autonomous et ce qu'on appelle allogénique. On va vous expliquer après, mais vous devez juste noter qu'il y a, on va vous donner des indications après, mais vous pouvez juste noter qu'il y a deux types de transplantation de cellules souches.
Next slide. When you talk about allogenic transplant, you need to do a test called HLA typing of the patient and siblings to see whether the siblings are completely matching to the patient or not, because there is a 25 to 30% chance that the patient would be a complete match to the sibling on HLA, which simply means that, let's say 100 people require transplant and have got siblings, 25 to 30 would be lucky enough to have a full match donor in the family. Please translate.
20 à 80% des personnes qui ont la transplantation de cellules souches ont cette capacité ou cette habilité-là de recevoir ça de leur famille, des frères et sœurs.
So now, next slide. So there are highly specific HLA tests which are called high resolution HLA typing. And in Fortis, we have got the facility to do high resolution HLA typing in-house as well. Please translate.
Ça, c'est un test à la maison, High Resolution HLA Typing.
Next slide. So the best donor is a sibling donor. In case you don't have a full match donor in the family, then there are registries in the world from where you may get a donor. The biggest registry in the world is in Germany, and the second biggest registry is in US.
Les mieux placés pour une donation, c'est souvent les membres de la famille. Au cas où vous n'êtes pas compatible avec les gens de la famille, là maintenant, vous pouvez chercher ailleurs. Et les pays où il y a plus de compatibilité, c'est l'Allemagne et aussi aux États-Unis.
So there is a problem in the sense that there is not even a single unrelated donor registry in whole of Africa. That's why if you don't have a full match donor in the family, it is difficult to find a full match donor for Africans because of the underrepresentation of Africans in the worldwide registries. Because if you don't have your own registry, it is less likely that you will get a full match donor from the other registries.
Le problème, c'est qu'en Afrique, si vous n'avez pas de donneurs dans votre famille, c'est très difficile de trouver parce qu'il y a moins d'1% des donneurs en Afrique qui ont été enregistrés. Donc, si vous n'avez pas de donneurs dans votre famille qui est compatible à vous, ça sera vraiment très difficile. C'est pourquoi eux, ils veulent améliorer ça, en bref.
Next slide. Let's see the indications of stem cell transplant. The indications are divided into cancerous and non-cancerous. Among the cancerous indications comes blood cancers, myelodysplastic syndromes, cancers of glands like lymphomas, brain tumors, neuroblastoma. These are the cancerous indications for which a bone marrow transplant is indicated. Please translate.
Les indicateurs des cellules de la transplantation des cellules souches sont ceux qui sont cancéreux, c'est les cancers des glands, la tumeur cérébrale et la leucémie et la myélodysplasie.
Yeah, then comes the non-cancerous or non-malignant indications. Among these comes aplastic anemia, inherited bone marrow failure syndromes, immunodeficiencies, sickle cell anemia, thalassemia, and metabolic disorders. So friends, for these problems, a bone marrow transplant can help a patient. Please translate.
Il y a aussi les indications non cancéreuses. Ce qui montre ça, c'est genre un désordre métabolique et l'immunodéficience.
Next slide. So let's talk about sickle cell. We know that sickle cell is a hemoglobinopathy. And if somebody has been suffering from sickle cell, he or she will have pain crisis, can have hemolysis, and can have multiple organ damage. And it can lead to morbidity. And if left untreated, can lead to mortality as well. Next slide. Please translate and then the next slide. Okay, so
you go back to the last.
Yeah, Nutan, please show the previous slide. Yes.
Okay. La drépanocytose et hémoglobinophobique, ça provient d'une simple nucléotide substitution.
Next slide. So sickle cell anemia is an autosomal recessive disorder. That means the two parents are carriers, and if two carriers get married, there is a 25% chance that they may produce a sickle cell anemia baby. Please translate.
Sorry, sir, can you repeat?
I'm saying, my friend, in sickle cell anemia, it's an autosomal recessive disorder. Just say autosomal recessive disorder, and the parents are carriers. If two carriers get married, there is a 25% chance that they may produce a sickle cell anemia baby.
OK. La dermapacytose est souvent résulté des parents, oui. Lorsque les parents sont souvent les porteurs. Lorsque les parents sont porteurs, il y a 25% des cas qui sont transmis aussi aux enfants.
Next slide. So this slide is depicting what I was saying, that the parents are carrier, and if two carriers are getting married, which means AS are the parents, if two AS are getting married, there is a 25% chance that they may produce a SS or a sickle cell anemia baby. This is what we have just discussed.
Comme on a dit,
Next.
c'est génétique et la dermapacytose, ce sont souvent les parents qui ont ça et c'est eux le porteur. Comme c'est illustré sur la photo, vous pouvez voir, lorsque les parents est RR et la maman aussi XS, ça peut créer des enfants qui ont ces hormones-là, SS, et qui peuvent genre acquérir cette maladie-là.
Next slide. You see the global distribution worldwide, around 250,000 babies are there with sickle cell. And every year the babies number is increasing. And out of this, 75% are born in sub-Saharan African nations.
Comme vous pouvez voir sur la photo, ça c'est la distribution des nouveaux-nés. Comme vous pouvez voir, il y a 240 000 à 330 000 bébés qui sont nés avec cette maladie ici. Et comme vous pouvez voir, ça augmente chaque année. Et 75% des cas sont dans l'Afrique subsaharienne.
Next slide. If you see the way the number of sickle cell anemia patients are increasing, we are expecting that by 2050, we will have 1,400,000 sickle cell children in whole of the world.
Si on voit par la façon dont c'est en train d'augmenter, on a fait des calculs pour dire en 2050, il y aura plus de 40 millions de personnes qui seront atteintes par cette maladie ici. Dans le
So
monde
sickle cell disease, next slide, can practically involve any part of the body. It can cause pain crisis, it can cause stroke, it can cause chest syndrome, it can affect the eyes, kidneys, bones. So any part of the body practically can be involved with sickle cell.
À n'importe quelle partie du corps peut être affectée par ce syndrome. Ça peut être la douleur au torse, tous ces petits syndromes-là sont des symboles de cette maladie.
In last couple of years, there has been a significant advances which have happened, like giving penicillin prophylaxis, providing vaccination to the patients who have got sickle cell. There have been a use of hydroxyurea. People are doing exchange transfusions. So these things are helping, but these are not a permanent solution. The permanent solution remains bone marrow transplant.
Quelques années en arrière, il y a eu des vaccins qu'on a donnés et ça n'a pas été vraiment une solution. Ça a été vraiment un calmant et ça n'a pas vraiment été une solution à ces maladies ici. La vraie solution, c'est la transplantation.
Next slide. Next slide, Nutan. Okay, if you see, HSCT means hematopoietic stem cell transplant is the only curative thing for sickle cell, and throughout the world, around 1,500 transplants have been performed till date.
Comme vous pouvez voir, c'est jusqu'à 1000 à 1500 individus qui ont eu cette transplantation dans le monde entier jusqu'à maintenant.
Next slide. So friends, any patient who has history of stroke, any patient who has got history of chest syndrome, any patient who has been having frequent pain crisis, or any complication related to sickle cell, despite being on medicines like hydroxyurea, not improving, is a candidate who requires bone marrow transplant. Please translate.
Pour toutes ces indications comme ça, données comme genre la douleur au torse, la toux, tout ça, s'il y a quelqu'un qui a ressenti ça, prendre des médicaments, ce n'est pas vraiment une solution, mais la transplantation sera la meilleure pour résoudre les problèmes, pour finir complètement avec la maladie.
Next slide. So there are pros and cons of each and everything. There is a pros and cons of transplant, but each and every family needs to understand that if a patient has been suffering and you don't offer a transplant, he will keep on suffering, and there would be a time when even a transplant would be too risky to be done. So sooner the better. We always advise families to get a transplant done early in their life.
Comme on dit, chaque chose a toujours ses avantages et aussi ses désavantages. C'est la même chose aussi avec la transplantation. C'est pourquoi on avise toujours qu'on puisse faire le plus vite que possible, dès qu'on détecte la maladie, qu'on puisse faire la transplantation.
Next slide. Next slide. So in a matched sibling donor setting, there is a 90 to 95% chance of cure, which we can offer, and our results are quite similar to what people produce in US, in Belgium, in France. So in India, we can have a 90 to 95% chance of cure for somebody who suffers from sickle cell by the way of bone marrow transplant.
Ici en Inde, il y a 80% de chances que la transplantation puisse être meilleure.
Next slide. Next. So if you see, this is a publication which was published in 2007 on long-term results of myeloablative stem cell transplant. And it has clearly shown that with busulfan, cyclophosphamide, and ATG-based conditioning, you can achieve a cure rates of more than 90%.
Comme vous pouvez voir par ce journal, cette recherche qu'on a publiée en 2007 sur la transplantation des cellules souches, montre que il y a de bons résultats qui sont en train de, comment dire, de résulter.
Next slide. Yes, so this is what I was talking about, a cure rates of close to 90% with busulfan, cyclophosphamide, and anti-thymocyte-based conditioning. Next slide. Same thing, next. So ATG is a very important component of conditioning, because if you don't add ATG to the conditioning, the outcomes will be 30% inferior. So it is important to add anti-thymocyte globulin as a part of conditioning when you do a transplant.
Il y a vraiment des composants qu'il faut ajouter, qu'on appelle ATG. C'est vraiment important d'ajouter là pour qu'il y ait une bonne transplantation.
Next slide. So almost similar outcomes are being reported from US, from this center called St. Jude's Children's Hospital.
Sorry, doctor, you can continue, please.
I'm saying almost similar outcomes have been achieved by this center, which is called St. Jude's Children's Hospital in US, more than 90% chance of cure. So similar outcomes we are also producing in India.
OK. Comme on a dit, il y a plus de 90% des résultats, de bons résultats qu'on a fait aux États-Unis. Et c'est presque la même chose que l'Inde est en train d'essayer de faire.
Next slide. So when people come to India, they are always worried with the long-term side effects like infertility, issues of scissor, and other thing. I think with the introduction and with the changes in the conditioning, the chances of infertility are also less, and you can achieve almost a similar outcome with slightly different conditioning regimens in India.
Jonathan, can you please take over?
Comme on le disait, pour ceux-là qui viennent en Inde, il y a aussi des risques que l'on découvre beaucoup plus avec les gens qui voyagent sur l'infertilité les plus élevées sur les femmes. Il y a des conditions et en passe. Yes,
John,
please.
can't hear you clearly. Could you please speak loudly?
Can you hear me now?
Yeah, a little better.
Oh, okay. Let me do this. What about now? Can you hear me?
Yes, now it's better.
Ok, on parlait de l'infertilité qui est aussi un des risques que l'on trouve chez les femmes, beaucoup plus les femmes les plus présentent un risque de plus élevé d'infertilité quand elles viennent pour les traitements. Yes, please, doctor, you can go ahead.
Okay, next slide. Oh, this is a busy slide, but I just want to summarize what this slide says. So if you do a transplant before the age of 16, the outcomes are around 95%. Whereas if you do a transplant after the age of 16, the outcomes are 80%. So it is always advisable to do a transplant early.
Ok, c'est pour ce qui concerne ces slides que vous voyez, je vais juste donner un aperçu. C'est que si vous faites une transplantation à avant l'âge de 60 ans, le taux de réussite s'élève à 90%, 90%, mais si c'est après 60 ans, alors le taux de réussite diminue un tout petit peu à 80%. Yes, please.
Next slide. So this is a publication which came in 2017 of the outcome of 1,000 recipients who underwent a transplant for sickle cell anemia, a matched sibling donor transplant for sickle cell anemia from 1986 to 2013. If you see, the overall survival is between 91 to 100%. That means very good outcomes can be achieved with the transplant for sickle cell anemia.
Ça, c'est une publication qui est venue à la COVID avec la COVID-19. Et comme vous pouvez le voir, il y a eu 1000 receveurs de greffes de frères et sœurs identiques réalisés entre 1986 et 2013. Vous pouvez voir que la réussite varie entre 91 à 97%. Donc, c'est presque fait à perfection. Yes, please.
Next slide. So it is not necessary that 100% of the donor cells are functioning. Even with mixed chimerism, some donor cells, some recipient cells, you can have a good and a healthy life for somebody who has got sickle cell after transplant.
Can you come again, please?
I'm saying that when you do a transplant, I request everybody to please mute their mics, because there is some disturbance which comes in between and then the memento gets broken. So please, requesting everybody to please mute their mics. So I'm saying that when you do a transplant, even if some donor cells are there and some recipient cells are there, still the transplant remains successful. So you don't need full donor chimerism. Even with mixed chimerism, you can have a good outcome. No problem. If you're not understanding, we move to the next slide. That's okay.
Et la première étude, c'est que même avec le chimérisme donnaire de 20 à 25%, si ces patients présentent ces symptômes liés à la drépanocytose, si l'on fait une transplantation, les résultats sont toujours bons. Yes, please.
Next slide. So you don't need every time very heavy dose of chemotherapy. With non-malleablative conditioning as well, you can achieve good outcomes in transplant. So you don't have to give very strong chemotherapy every time. Even with less intensity of the chemotherapy, good outcomes can be achieved.
Il y a toutefois, vous pouvez toujours avoir de bons résultats, comme on le disait, même si vous êtes HTC non myélo-ablatif.
Next slide. So these are all things very technical. Let's move on to the next slide. Next. So so just before this, the previous slide. The previous slide. Yes. So if you do a non-myeloablative conditioning transplant, there are less chances of toxicity, less chance of infertility, and patients can preserve their fertility. That's the advantage.
Voici le schéma de non-milieu ablatif et voilà les avantages qu'il présente. Il y a moins de chances de mortalité liée au traitement et à la préservation de la fertilité, il y a plus d'accessibilité plus tard au cours d'une maladie compliquée. Yes, please.
Next. So if you don't have a full match donor in the family, nor you have a full match donor out, next slide, the previous slide, the previous, yeah. So if you don't, no, the next, yeah. So if you don't have a full match donor in the family, neither you have a full match donor outside the family, still transplant can be done, called a haploidentical transplant, which by taking father or mother as a donor, because 50% genes comes from father and 50% genes come from mother. So you can do a half match transplant and you can have good outcomes.
Ok, toujours, vous pouvez avoir de bons résultats même si vous n'avez pas de TMS. Je pense que c'est un terme technique que les docteurs comprennent déjà, puisque il y a la contribution de 50% venant du père et 50% venant de la mère. Même si vous n'avez pas de TMS, alors la transplantation va pouvoir des résultats positifs. Yes, please.
Next slide. So this is the outcome of half match transplants from US, St. Jude's, and they have produced very good outcomes even in a half match setting.
Ok, et voilà les résultats de cette transplantation qui s'est faite aux États-Unis d'Amérique. C'est une publication et vous pouvez voir que cela a produit de bons résultats.
Next.
Yes, please.
Next. So with half match transplant, you can achieve 85 to 90% chance of cure. So even if you don't have a full match donor in the family or outside the family, still a transplant can be done with good outcomes. That's what every family and every doctor needs to understand.
Ok, on en revient toujours au même cas de la transplantation, parlant de ces noms, des gens n'ayant pas de DMS, ainsi de suite. Où la transplantation est toujours faite à succès.
Next. It is quite technical. We'll not discuss this. Next. Okay, so I would like to conclude by saying this previous slide. I would like to conclude by saying this. If you have a full match donor in the family, you can achieve a 95% chance of cure. If you don't have a full match donor in the family, a 90% chance of cure can be achieved. And transplant is the only curative option which the families and the doctors need to understand for sickle cell.
Oh, Jonathan, you're on mute. Please translate.
Je disais le HSCT pour le patient atteint de drépanocytose sévère provenant d'un frère ou d'une sœur identique offre une excellente survie à 5 ans avec un pourcentage de 95%.
Next. So this is how we collect the stem cells. So the donor is in the blood bank, is happy, and it is not painful, neither it is risky for the donor. This is how we collect the stem cells.
C'est là où nous faisons la collecte interne des BPC.
So in case we want to use the stem cells later, we can cryopreserve these stem cells in the hospital.
Si nous voulons l'utiliser après, nous allons devoir le sauvegarder dans ce que vous voyez là.
Next. So when we collect the stem cells, we need to check whether we have collected the sufficient stem cell dose or not, and we have got in-house facility for that.
Ok, et nous Nous avons toutes ces facilités, ces départements pour pouvoir voir la qualité et la quantité de ces gains nous collectionnons. Yes.
Next. So in our hospital, we have got a 20-bedded state-of-the-art BMT center, and next year we'll add 18 more beds. So next year we'll have 38.
Donc, dans l'hôpital, il y a aussi cette unité de collecte, cette unité BMT ultra moderne de 20 lits. Yes, please.
Next slide. This is how our BMT room looks like, and all the rooms have got positive pressure.
Voilà comment est-ce que notre chambre de collecte BMT, c'est à quoi il a l'air, l'unité ultra moderne dont on a parlé.
Next. This is a biosafety cabinet for mixing the chemotherapy. Next slide. This is our team. So we have got 6 pediatric hematologists, 6 adult hematologists, and this is the whole team which take care of the transplant patients.
Voilà un peu notre équipe pour la transplantation. C'est là qui s'occupe des patients. Pour la transplantation, nous avons, comme vous le voyez là, il y en a 6 pour la pédiatrie.
Next slide. So these are some of the patients who have been transplanted. This is my first patient from Nigeria who was transplanted for sickle cell anemia 10 years back.
Voilà, ces patients sont parmi les premiers patients qui ont passé à la transplantation, venaient du Nigeria.
Next. Next. These are some other families. Next. So in our center, we have done more than 150 transplants for sickle cell anemia.
C'est d'autres patients que nous avons. Nous avons fait plus de 1000 transplantations. You said 1000 or 100?
So
Sorry.
in our center, we have done more than 1800 transplants, but for sickle cell, 150.
Ok, dans notre secteur, nous avions fait beaucoup plus de 800 transplantations. Yes, please.
Next. So this is my room. So this is because I am a pediatric hematologist. Our kids, they draw, and this is the most rewarding thing for us.
Ouais, pour le docteur que nous sommes, voilà ce qui nous récompense le plus.
Next. This is our oldest sickler who has been transplanted, who is 34 years of age, on your left.
Ok, là, c'est un des patients qui est passé par la transplantation. Il a 33 ans.
Next. These are some more patients. Next.
Ça, c'est encore d'autres patients.
Some more.
Encore
plus. So why choose India? The cost of transplant in India is much lower as compared to West, and India has become a place for medical tourism, and that's why people come to us from different parts of the world.
Pourquoi faire le choix sur l'Inde? Parce que le prix pour la transplantation est beaucoup plus bas comparé aux Occidentaux. Voilà pourquoi même le tourisme médical se dresse beaucoup plus du côté de l'Inde à cause de l'affordabilité, de l'abordabilité.
Next. Sorry. So now we have done more than 1800 transplants. So this is a picture which we celebrated 1000 transplants almost 3 years back.
Comme on a fait plus de 800 000 transplantations, là c'est une photo où l'on célèbre la barre de 1000 transplantations qui a été.
With that, I would like to thank you all for a patient hearing, and I would be more than happy to answer any questions if you have.
Merci bien pour votre présence ici et avoir été patient. Je serai plus que content de recevoir vos questions.
Thank you, Dr. Vikas. I have some questions which I've received in chat, and I have some questions which I've received earlier in the form. So
okay.
I think if someone from the call wants to ask, let's prioritize that. Dr. or Nana Paul, you asked two questions. It would be great if you can ask it yourself on the call.
S'il y a de cela,
Ok.
on a quelques questions qu'on doit devoir présenter au docteur, mais s'il y a des docteurs qui participent au webinaire qui ont des questions, nous allons prioriser d'abord cela. Si vous avez des questions, soulevez la main et puis on va vous choisir.
Okay, so thank you, Doctor, for your fantastic presentation. Very straightforward. I have a number of questions I want to ask. I don't know if I should ask all of them at once, or let me ask them one after the other. But my first question is, what is the umbilical cord transplant about? Can you just give me an idea of what it is all about?
Yeah, when a newborn baby is born, from the placental side of the cord, 25 ml of the stem cells are being collected and they go to a public bank or a private bank. And later, in case you want to do a transplant by taking a cord blood unit, you can use that unit.
Okay, so is it done for all babies or babies who are sickle cell patients? Who are sickle cell born?
Yeah, you can do for any condition, but in India, we don't prefer to do a cord blood transplants because there are quite a number of issues with cord blood transplant. That's why we prefer a adult donor transplant as compared to a cord blood unit.
Okay, all right. Thank you for that. So the other question is that is there possibility for transplant for CA prostate?
There is no role of bone marrow transplant in CA prostate. No role.
Okay, you mean it can be done, right? Any research being done on it?
No research. There is no use of bone marrow transplant in sickle cell. In CA prostate.
Okay. So you talked about the fact that there are only two places in the world where we have a bank for, is it bone marrow donors or something? You said USA and Germany, right?
No. I said that the biggest bank is in Germany. The second biggest is in US. But there are many other banks in other parts of the world as well, but not even a single bank in Africa. That's what I said.
Okay, could it be because there are no specialists in that area in Africa, or what do you think, in your opinion?
That's one of the reasons, because the transplants are not happening in Africa other than South Africa. I think in Nigeria, in Benin City, there are some transplants happening. So all of you need to come together and you need to have your own registry so that in case somebody requires stem cell, you have your own bank. So you people have to come out with the solution.
So do you have a bank in India?
Yes, we have a bank by the name of Datri. If you go to Google, you will find DATRI, Datri.
Okay. So that means that if we refer clients to you from Africa or for Nigeria, to be specific, could that mean that there will be a challenge since we don't have a transplant bank in Nigeria?
Yeah, there is a serious challenge, because if you don't have a full match donor in the family, the second best option is to do an unrelated donor transplant. So you don't have your own registry. So then the option left for an African, if he doesn't have a full match donor in the family, is unrelated, is a half match transplant by taking father or mother as a donor.
Okay, so going forward, it means that how do we now, if we have, I know there's quite a number of significant patients in Nigeria who have sickle cell issues. So which means what procedure will you have in place if we want to refer patients to you that will save them the stress of getting there and not finding a match?
Yeah, that's a very good question. So if a patient doesn't have a full match donor in the family or outside the family, then they can come with the parents. 50% of any child's genes comes from father and 50% of any child's genes comes from mother. So parents are at least 50% matching, and that's called a haploidentical transplant. So we can take father or mother as a donor and do a transplant with good outcomes.
Okay, so that means it's advised that their parents should come with them to travel down to India, right?
Undoubtedly, my friend, yes.
Okay, that's great. Thank you very much. I love your presentation.
Thank you.
Thank you, Dr. Paul. Then we have next question from Dr. Navala Gabriel. Dr. Gabriel, if you want to ask the question yourself.
Bonjour.
Jonathan, please translate.
Hello, doctor. Go ahead. Allez-y, parlez. S'il vous plaît, docteur, vous pouvez poser votre question. He just greeted you, doctor. Looks like it's not there anymore.
Then we can
Merci,
also
ici, là.
question.
Cher docteur, vous êtes toujours là?
All right. So I think Jonathan is not answering. Let me ask the question in chat then. So there's a question by Dr. Navala Gabriel. Can the same principles apply in children with cerebral palsy? Dr.
Oh,
Vikas.
that's a very good question. But somehow, my friend, there is no role of bone marrow transplant in cerebral palsy. There are researches going on whether transplant helps for cerebral palsy, but we don't have an answer in black and white. So at the present moment of time, there is no indication for doing a transplant for cerebral palsy.
Then we have next question from Dr. Anthony from DRC. Dr. Anthony, if you want to ask your question yourself, Jonathan, if you can check with Dr. Anthony, or else I'll read what he has written.
Docteur Anthony, vous êtes là? Docteur Anthony?
Oui,
Allez-y, posez votre question. Hein.
oui, j'ai trouvé le sujet très, très intéressant.
Can you hear him? Because I'm having trouble. I don't know if it's only me.
Jonathan, we can hear you. I think there's issue with Dr. Anthony's.
Docteur Anthony, allez-y, s'il vous plaît, parlez un peu à haute voix.
So let me read the question in English, and then you can maybe translate the answer which Dr. Vikas suggests. So Dr. Vikas, the question is.
Ok, on va lire votre question. On va lire votre question et puis on va traduire la réponse que le docteur va vous donner.
Is
C'est
there
bien
any
comme vous avez dit envoyé.
for successful bone marrow transplant sickle cell disease?
Sorry, can you just ask the question again?
Yeah, the question is there any age limit for successful bone marrow transplant in a sickle cell disease?
That's a fantastic question. I said that sooner is better. It is better to do a transplant early, but we have done transplants even for adults as well. So I showed a picture of a Nigerian person. His name is Mr. Buhari. His transplant was done at the age of 34 and he's doing well.
Yeah, okay, at the age of 24 or 34?
34.
34, thank you. Ok, docteur Anthony, pour répondre à votre question.
J'ai trouvé que c'est intéressant parce qu'il y a un taux de prévalence, il y a une prévalence assez élevée par rapport à la drépanocytose ici. Et la préoccupation première, c'est que j'aimerais savoir si est-ce que la greffe de la myose, y a-t-il une date?
Encore une fois, vous êtes coupé à la fin, là, je n'ai pas saisi. So he said that was a good topic. He really liked it. Since in the Congo, that's what we are facing. There's a high level of that syndrome. So he's asking a question, but that part I didn't get it because the catch is breaking up. So let me translate the answer you just gave him, and then we'll wait for his second question. Sorry. Docteur Anthony, pour la première question que vous aviez posée, hein? Est-ce que vous nous suivez, docteur Anthony?
Oui.
Pour la première question que vous avez posée,
j'aimerais savoir si, concernant... il y a un âge limite. S'il y a un âge limite pour un candidat.
Ok, on a répondu. Voilà la réponse que docteur Voici la réponse que le docteur Vikas a donnée. Il a dit, quand il parlait d'en présenter, il a parlé de l'âge, en tout cas, il n'y a pas de l'âge limite. C'est que c'est recommandé que vous les fassiez le plus vite possible. Donc, le plus vite, c'est mieux. Donc, une fois que vous remarquez qu'il y a des drépanocytoses, vous pouvez conseiller à ces gens-là, à la famille des patients, de pouvoir le faire le plus vite possible. Là, c'est la recommandation. Mais en outre, Dernièrement, ils ont fait une transplantation chez un Nigérien, il est âgé de 34 ans. Et ça s'est très bien passé. Donc, pour ce qui concerne l'âge, il y a juste une recommandation qu'on les fasse le plus vite. Le plus tôt, c'est mieux. Vous avez suivi, docteur Anthony?
Ok, oui, oui, j'ai suivi ça. Oui, la seconde préoccupation, là, c'est beaucoup plus en termes de coût. Hein, j'aimerais
Allez-y avec
savoir
la
si
deuxième question.
Oui, la deuxième question, c'est par rapport au coût. J'aimerais savoir à combien reviendraient les coûts globaux. Par global, j'inclus carrément tous les séjours, les soins compris, si les donneurs doivent être là-bas ou s'ils doivent venir.
Okay, so the second question is all about finance. I don't know if that's the right forum, but it's saying how much can it cost? It means the accommodation, the treatment, and if the person should travel all the way to India for that transplant.
Okay, that's another good question. So for a matched sibling donor transplant, roughly it is around $25,000 for the transplant. For a half match transplant, it is around $35,000. For accommodation and other things, you need $10,000 more for the logistics. So roughly $35,000 when you're coming for a full match, and $45,000 for a half match.
Okay, so like $35, $35,000
and $45,000 full match.
Ça s'élève, si ça s'élève à 35 000, de 35 000 à 40 000 dollars pour tout et l'accommodation, ainsi de suite. Tout inclus.
Ah, ok. Ok, d'accord. Là, c'est un séjour de 1 mois. Les malades, il va faire 1 mois là-bas. Il va faire quelques semaines.
So doctor, for that amount of money, is it like for a month? How long would the patient be staying there? So is it like for a month or weeks?
3 months. 3 months.
Yeah, pour 3 mois. 3 mois.
Ok. Ok, merci beaucoup.
All right. Thank you very much.
Jonathan, we have another question from Dr. Bafuma from DRC. If you can check with him as well.
Dr. who? Sorry.
Bafumba from DRC.
Docteur Kafumba, je pense qu'on n'a pas massacré votre nom. Docteur Kafuma ou Kafumba, s'il vous plaît.
Bafumba, Bafumba, if I'm pronouncing it correctly.
Yeah, Docteur Bafumba. Êtes-vous là?
Oui, je suis là.
Oui, allez-y, Docteur Bafumba. Posez votre question.
So
Dr. Bafumba, vous m'avez dit?
I have his question translated of the text. No, yeah, he's on the call. He was trying to speak. I have the question translated. Let me share it with Dr. Vikas, and then you can maybe help translate the answer.
All right.
Question is, how do you find HL? Yes, Dr. Continue.
Hello.
Oui, Dr. Bafumba, allez-y.
Oui. Merci.
Bon, comme il y a vraiment de bruit là où vous êtes, au docteur, comme ça, moi, je vais faire la traduction de la réponse. C'est bon, non?
Just let me ask the question. You can help translate the answer. I have the question. So, Dr.
Yeah,
Vikas,
this is what I'm explaining him, that you got the answer to the question already translated, and just since he's in a noisy place.
Right. So, Dr. Vikas, the question is, how do you find HLA compatible donors? And if they have to be found in the family, what criteria should be used to split family?
So I said that during the presentation, I said that we do the HLA typing of the patient and siblings, and there is a 25% to 30% chance that the siblings are fully matching. So you need to do HLA typing, and you will come to know whether the siblings are matching or not.
Jonathan, can you please help translate the... Jonathan, you are on mute. Please help translate to Dr. Bafumba the answer.
Donc, lorsqu'on va fermer votre micro, ça émet un peu le... Okay. Sorry, Dr. Vikas. We couldn't get you because of the background noise.
So I'm saying that you do the HLA typing of the patient and siblings. There is a 25 to 30% chance that the siblings are complete microdrotation on HLA. So after doing the HLA typing, you can come to know whether you have a full back donor in the family or not.
Ok. En prévision avec ce qu'on a présenté dans notre webinaire, on a parlé de collection de souches à partir de la sœur, et il y a un pourcentage de 25, le pourcentage s'élève à 25. C'est comme ça. I didn't even get a question.
All right. I think we can take one last question, Dr. Vikas, if you're available for 5 more minutes. And it's spilling over.
Yeah, please go ahead.
Yeah.
Please go ahead.
So anyone wants to ask last question? I think Dr. Fred, you have asked about a patient. I'm assuming it's a current patient.
Can I ask one, Dr. Kalu?
Yes, Dr.
Can I ask one question?
Yeah.
Yeah. Okay, cool. So I just wanted to ask, for the kids, I know they have to be like immunosuppressed for a period of time. I wanted to just know how long exactly are we looking at them being immunosuppressed?
That's
the time frame?
Doctor, that's a very good question. So usually after 1 year, we stop all the immunosuppression. After 1 year, we stop all the immunosuppression. Whereas only 10 to 15% patients who get chronic GVHD require immunosuppression for longer duration of time. But in majority of patients, we stop immunosuppression after 1 year of transplant.
Okay. Thank you.
Thank you very much, everybody, for joining. And if there are no further questions, can I take a leave?
Yes, thank you, Dr. for taking out your time on a Sunday.
Sir, I would request if we can, all of us can switch on the camera and just have a quick photograph together.
Yeah, sure. I'm switching on. Yes.
Est-ce que c'est une requête? Pouvons-nous tous ouvrir nos caméras pour que l'on puisse avoir un screenshot? Pour les docteurs, s'il vous
Are you
plaît.
taking the picture?
Yes, I'm taking the picture.
Are we done?
C'est une photo d'ensemble, si nous pouvons...
Yes, ma'am, we are done. Thank you, everyone.
Thank you. Bye-bye. Thank you.
Thank you, sir. Thanks a lot.
Thank you so much, sir. Thank you. Yeah.
Thank you, Jivo team, for organizing
Thank
this.
you very much.